Continuing conference committee, S.126. And I understand that the Senate has some language that they've given to our legislative council, and Jen's going to put that language up for some proposals.
Good morning, Jen Carby, Office of Legislative Counsel. I have titled this document, Senate Conference Proposal number 1. There may not be a bunch of back and forth, but if there are, at least this way we can keep track. So what I've done is I'm showing the changes that the Senate is proposing to put back in from their original bill that they passed in yellow. Changes from that are in green. So things that are different from what was in the Senate bill originally.
Okay.
You'll see in green. So I'll show you when we get there. So first we have in the purpose and goals section, keeping everything as it was from the House document, as House version as the underlying document, adding back in the reference to continuing on from reference-based pricing to global hospital budgets. And you'll see some of this throughout.
Can I interrupt really? Kristen, where is this posted?
Just posted, so you're gonna.
Is it going to be on healthcare or? Okay, thank you. Sorry, Jen. Go ahead.
Good point. Then in the duties to establish standards for global hospital budgets, the difference in the language from what the Senate had proposed was adding references saying to the extent that resources are available. And then you'll see at the very end in the appropriation section, there's some intent language around resources being available.
Can I ask, the reference-based pricing we have as 2027, do we specify whether that's hospital fiscal year 2027? We do. Okay. So this would be reference-based pricing would be established in hospital fiscal year 2027, and then moving on starting for fiscal year 28.
For one or more Vermont hospitals that are not critical access.
Okay,
right. And then again, by hospital fiscal year 2030, to the extent that resources are available, the board would establish global hospital budgets for all Vermont hospitals. And we are in the reference-based pricing section. And I don't believe there were any changes here, except they have proposed changing the name of your primary healthcare steering committee to be the Vermont Steering Committee for Primary Healthcare. I don't know if
I'm sorry, I'm laughing. Can we just move the words around?
Well, we added the word Vermont, so it is now the steering committee for primary care for the state of Vermont.
Okay.
And you'll see that reflected throughout.
Okay.
No changes in section 3A, definition of hospital network. Section 4, the hospital duties, they have in this proposal agreed to take out that additional information for the hospitals to provide regarding numbers of employees, employee compensation, some of that information that you heard the board already receives or has access to, and also on proposing ways that the hospital can support services in the community. Section 5 is the hospital budget review, and the big change in here, in addition to maintaining the deletion of the excluding certain service lines from net patient revenue. So they did not put that back in. But they did put back in global hospital budgets, again, with this language around to the extent that resources are available. Then we get to section 6, the hospital networks, and I don't believe there were any changes there. They went with your suggestion around the board recommending action only. Healthcare contracts, they took your suggestion for adding the language back in and maintaining their addition. Then we have, again, the name change throughout. So we have Vermont Steering Committee for Primary Healthcare, and change that reference in section 8, which is on the strategic plan. Most of this stayed the same as well. The provisions of the plan, they did propose deleting in this identify list, identifying specifically disparities in reimbursement rates. So sticking with the barriers to access to services, but not pointing specifically at reimbursement rates.
They can still do it.
All right, they can still do it. Then adding in some language specifying that state agencies shall cooperate with all reasonable requests from the agency for data and other information and assistance needed for the agency to prepare and update the plan pursuant to this section. So this is kind of instead of their who contributes what, is to give them, give the agency some assurance that other state agencies are directed to be helpful.
Yeah, of course, Topper.
What does all reasonable plus? What does that mean?
Well, I started to say all requests, but if the request was that somebody else write the report or write the plan, that might not be a reasonable request. So it's really to sort of caution both sides that AHS should not ask for things that are kind of beyond the scope of what would be normal or reasonable, and agencies should be prepared to comply. It's really, I mean, it's really within the judgment of the two agencies. If there was a real issue about it, as far as enforcement goes, I don't know, they might have to come back into the legislature and ask for better language. But I think this is fairly standard language about asking people to be reasonable with their requests and asking the recipient of the request to be reasonable about complying.
Oh, I'm sorry. Go ahead.
And yes, yesterday, the agency that's going to provide, try to pull all of those meetings and everything together. So that's where I'm just trying to figure out who's going to make that decision. It looks like it's in limbo.
Well, the Agency of Human Services is still in charge of everything.
Yeah, but if
They're still the ones running the show. But this is requesting, and we have this in many places in statute where we direct state agencies to comply, to cooperate. Whether it's, I think we have this for the Office of the Healthcare Advocate, that state agencies have to comply with reasonable requests from that office for information. So this is cooperating with reasonable requests for data and assistance.
I just don't like, if it doesn't work, they come back to the legislature. We already had it fixed so that they had to do it.
So this is a proposal.
The new proposal, we'll take that under advisement.
What state agencies are we talking about?
So if you look at page 25 of what we were looking at yesterday,
Mhm.
and you'll see there, you had struck C under that section, that the Green Mountain Care Board shall contribute data and expertise related to its regulatory duties, and so on. So this is a way of saying, this didn't seem to you an appropriate way to get information and data to accomplish the goals by the agency. So this is a replacement for that. And so the AHS couldn't, for example, ask for a new research project because they need certain kind of data. That would not probably be reasonable. Might want to do it, but it doesn't seem to me that would be a reasonable request. So looking for the data that's available, I mean, you could put something like that in from available data. You could put that in, but it could go beyond that if there was an agreement. So it's just simply to get information that the agency would need in order to complete its goals. So
What state agencies are we talking about here?
I think it depends. It could be
could be any.
yeah, it could be Green Mountain Care Board, Department of Financial Regulation, some of the departments under the agency, Department of Health.
I mean, it could be transportation if they were looking
Right,
at
it could be
67 plan. For where are we with?
that's true, around
emergency
access.
Transport.
Right, and around
There's a lot
access,
of things
yeah.
that could be asked for. It's simply putting in place that stuff.
All right.
Not meant to in any way to.
Doesn't seem
undermine the
punitive.
agency.
Mm-mm.
No, I think to my mind, it sort of puts the other agencies on notice.
Okay.
That they may be called upon to provide information and assistance. All right, and then
I just have to practice.
the dates. So the language that had been in the bill as passed by the Senate had from 2025 through 2027, the agency engaging with stakeholders, collecting and analyzing data, gathering information from Act 167 processes and soliciting public input. This would make that 2025 and 2026, with the agency preparing the plan in 2027 and providing the plan to the legislature by January of 2028. So the Senate version had 2029 for the first plan. House.
What's that? Mari.
Sorry.
So the House had 2027 for the first report. The Senate had 2029. This proposal is for 2028 for the first plan. And then to go to back to the Senate's original position of a 3-year update, with that coming in by January 15th every third year. And then they're proposing beginning that in January of 2031.
Jen, when does the global budget? Back in the front, it said something about global budgets being done by, I thought it was 28.
So the first, at least one non-critical access hospital by hospital fiscal year 2028, the rest online by hospital fiscal year 2030. But that's the Green Mountain Care Board doing that work. This is the Agency of Human Services doing the leading the plan and the plan updates.
We had it coinciding with mid-year of each biennium, correct?
Yes.
So if we did it every third year, well, now every other time that they do it, it would be at the beginning of a session as opposed to in the middle of a session. Why, I'm curious why a plan that I am thinking of as an iterative, ever evolving, keeping an assessment of needs and continual update. I'm wondering why you're changing it from 2 to 3. If they're continually working on it, why only every 3?
I think it's just a matter of time and the work involved across the state. That's all. I mean, theoretically, you could think about having it begin with a certain time frame and then change to another one. So as you get more into the process, it might be easier to extend it out further. But we from the beginning think that it's really critically important to give the agency and others, so there are a bunch of people working on this. It's not just one, it's a whole group. And it's not just the advisory group. It's the whole state, all the hospitals, just to have time for that, to collect information, to make change, to inform next steps. Really, that's really the timepiece. So we can, we'll have to think about that.
Jen, do you happen to have any idea how often the HRAP Health Resource Allocation Plan is to be updated currently?
I want to say every 4 years.
Yeah, something like that.
Something close to that. Okay.
All right. Section 9 is the Healthcare Delivery Advisory Committee. So one of the things that the Senate is proposing is to specifically add to the duties of the Healthcare Delivery Advisory Committee to consider the recommendations of the Vermont Steering Committee on Primary Healthcare. And to provide and specifying that their coordinated and consensus recommendations to the General Assembly be on issues related to healthcare delivery, specifically including primary care and population health. And then they are proposing to change the number. So you may recall there were 14 members in the advisory committee as it came from the Senate. There were 19 members in the House proposal. They have suggested here 15 members. They have moved a few of the members to a consult with capacity. So they have proposed taking out the member of the Health Equity Advisory Commission and instead putting in 2 members of the Vermont Steering Committee on Primary Health Care to create that connection between the two. Taking out the representative of advanced practice registered nurses, the free clinic program, independent mental health professional, small business, and VPQHC, and instead specifically directing them to consult with and solicit input from the Health Equity Advisory Commission, advanced practice registered nurses, physician assistants, mental health professionals, and other healthcare professionals who are not members of the advisory committee, small businesses, Vermont's free clinic programs, VPQHC, and other relevant stakeholders. Making the group itself smaller, but requiring them to consult with and solicit input from those entities and others, and then just renumbering. If you want to say anything.
Yeah, obviously, we could extend the advisory committee to include advanced practice nurses. We could also include physician assistants. We heard a great deal from them about all of this. And mental health professionals, other standalone professionals. Or rather than do that, we thought we would keep the group smaller and then have them consult with and shall consult with, so they must consult with these other groups, and allows the other groups to really provide some direct input to the work that's going on. Not seeking to exclude anyone, but to make the advisory committee give it, ability to act quickly, more effectively, have a quorum at meetings, pull together, that kind of thing.
Topper, did you have a question or concern?
Yeah. What we do, and we continue to do that, is we do not have that type of, those groups at the table with a vote. And they're the core of the healthcare system. And they specifically have been asking, especially the nurses groups, to have a say, to be part of the group that's going to vote on something rather than just consulting. And I know it says shall consult. So, Madam Chair, you can think about that.
Oh, I hear you. And, I think that the advanced practice nurses are key to primary care. So I can't imagine that they wouldn't be involved in the whole primary care discussion. There's no question about it. Similarly, when we heard from physician's assistants, they're especially those who are independent of any hospital relationship, that they are also feeling disenfranchised. Oh, theoretically, we could add a list here that goes way beyond 19 or 20 or 30. The goal here is to have a committee that can work with alacrity, can make decisions, can pull a quorum together, feels and is committed, and at the same time, really involving all the groups, everyone who's listed there. I don't think there's any intent at exclusion. How else we do it is.
See, Jenny, what I'm thinking, what's in my mind is that whole group is the core of primary care.
Well, I would see primary care physicians, independent primary care physicians, FQHCs, and others are really core, and long-term care.
Mental health.
Yeah, there's a lot. Every stage of life has a different primary care investment, so a professional investment. So for me, I think that's where we're trying to get to here, and then having the folks who are decision makers and advisors, such as AHS, Green Mountain Care Board, Healthcare Advocate involved. The Primary Care Steering Committee is defined. They're key in this. That includes. I would think they would be looking at their PAs, their APRNs, their physical therapists who are all working together to improve primary care. There's no intent to leave people out, but it is to consolidate and make more efficient the work. That's it, really.
I do appreciate, um, I do appreciate the inclusion of the two members from the Vermont Steering Committee on Primary Healthcare. My concern, as I look through this list of 15 people, and, you know, oftentimes, and we form these committees, and you don't want to leave anyone out. And I am guilty of making things longer when I start with saying it should be 3 people, and that's it. And then it turns into 19. My concern, though, is when I look at various people and the representatives of various organizations or constituencies, I often think about who's representing finance and who's representing Vermonters' healthcare. And feeling as though a lot of the people that have been eliminated are the ones that are really representing the care that's delivered as opposed to the finance of how care is delivered.
Well, let's look at that.
Okay.
I mean, look, I would actually ask you to look at that as well and think about it. For me, I can't, if we go, can you scroll up a little bit, Ken? Keep going. I'm just looking at there, sorry. I mean, if you're talking about those folks who are independent physician practitioners, you're talking about members of the primary care group. These keep going up and down. I don't know. I can't look at them all. I can't look at them all at one time, but I can't imagine that they don't have the best interests of patients in mind. And honestly, when we did Act 27 and we went through an analysis of what are the barriers for people, from that came a lot of information. Act 27 of 2022, somewhere, or 21, that was before pre-pandemic. Cheryl Hooker was here, it was 2020 maybe. I can't remember, but it has a lot of information about patient access and information that can also be relied on here. But I'm thinking the goal here is not to exclude anyone, but to include, and shall consult with, I think is pretty powerful. Also adding in primary care folks from the Vermont Primary Care Steering Committee also gives primary care a stronger seat at the table. I had an email this morning from an independent primary care doc who's very concerned about her patients. And she's communicated with me several times. These are folks who care about how they support the patients. Well, I don't think we're excluding. I think we're trying to make it a process that is more effective. Now, the group sits at the table. You think that Mike Fisher sitting at the table isn't going to say, wait, you're not considering the patient here? So I'm, I think about it. That's all I can say.
I do appreciate, trying to streamline it and make it more efficient. I know that
So think about how you might
just by creating
restructure. I mean, once you put in,
forums.
but once you put in one profession, you need to have all the professions there. So how far does it go? Just the question. And you got people at every age group and developmental stage with different needs. So we've tried to put in from pediatrics to the long-term care. So I think it's big.
Thank you, Daisy.
I just, I think the chair said it really well that, this is about service delivery reform and that these are the experts who can really speak to those patients. I mean, do you really think a physician is going to speak to a mental health patient? You and I both know they're not. That's not their patient. They don't know the specificity of which you have to treat that person with. And there are some very specific things you have to treat them with.
Which is
And
why
so I
health.
fully support
Yeah.
what she's saying about why we need to have these voices at the table, because we haven't had a bill like this in a very long time, and I'm so grateful we do. And these people told us they want to be at the table, and I think they deserve to be there during a massive reform like this.
Okay, so they can, this group, I hear you, the commissioner of one preferred provider outside the designated and specialized service agency system, outside of that system, selected by the commissioner of health. So you do have a mental health professional sitting at the table.
So that would be like an SSA, right? We have our DAs and SSAs.
Outside.
Outside of,
So can we specify that one that it's selected by either the commissioner of mental health?
I think the preferred provider system, if I'm remembering, is the substance use disorder treatment
SUD.
that is, and the preferred providers are determined by the commissioner of health.
Okay,
So you've got the Vermont Care Partners and.
That preferred provider.
All I wanted to say was I think I'm partially to blame for this because I really was making the point of having an efficient group and I was worried about getting a quorum and, just having been on large boards, they're just hard to manage. So, I just wanted to say, it wasn't to exclude anyone. It was more about getting down to like an efficient size.
We're asking them also to consider certain things in their deliberations. So what they're asked to consider in terms of mental health delivery system, substance use disorder, primary care, all of those things.
I appreciate the need to get it down to an efficient size. I would ask that possibly we might want to think about adding at least one more professional who works in the mental health field, because I think we lost a little bit of that, not within our designated agencies or SSAs, and not necessarily specifically substance use disorder, but I think with the crisis that we have in mental health care, we need to ensure that they have a very prominent seat at the table for Vermonters.
All right, well,
Possibly adding back
let's
in.
consider that. Yeah, let's do that.
Thank
Yeah,
you.
let's leave it at that,
Okay.
consider it, because small business too, it's a big deal for them. They're never at the table. Okay,
Okay. So how many members would that make?
That would
Well,
be
we would go back to
17.
16 or 7.
17. Okay, well, yeah, let's try that. We can try that. I know small business is important. That was a hard one to take.
Section
Hard
9,
to take out. I
section
agree with you.
9A is the Vermont Steering Committee for Primary Healthcare. I'm proposing to just move where it's codified. Having just reviewed the House proposal on H.266 this morning, that would also create a 18 BSA 9407. So I'm suggesting we move this to be with the advisory committee we just looked at and leave 9407 available. Otherwise, I have to figure out recodification over the summer. So the name would change. That is the first difference here. And then just a little more specificity around providing input into the statewide healthcare delivery strategic plan. They wouldn't just provide input into it, but provide input regarding primary care for that.
I just want to make a point because I put a lot of thought into this. And there's one word that I really would like to put back in. Because I think that oftentimes when we think of primary care, we think of medical care. And well, I know that we don't, but I really want to be certain that we are, we are making a strong statement that we feel as though primary care is comprehensive care. And that includes, not only preventive care, chronic care management, primary care, what we typically think of as primary care, but also primary mental health care. Again, I go back to the blueprint for health and what the blueprint for health, what it imagines, what
Community health team,
is-
depending on the
that
patient.
is comprehensive healthcare. And I feel like if we get rid of the word comprehensive in both the title of the steering committee and as well in this one piece where you just had, which thank you so much for
Well, so
clarifying.
why don't you
and
put
adding.
it after the Vermont, back up to the title.
Vermont Steering Committee.
And just say the Vermont Steering Committee for Comprehensive Primary Healthcare.
Love
Is
it.
that better?
Love it.
And what's the acronym for that?
Many
Oh,
letters.
that's right. You're right, we should try out the acronym.
Yeah, no vowels. I have no vowels.
No vowels. Can anyone think of anything with a vowel that we can do here for a better acronym?
All right.
I'm fine with that. That was not an intentional omission.
But I think that I really like your addition of the language on what it is that they're providing input in. And I would just say that we say, right, but regarding comprehensive primary care.
Okay.
An important word.
Then we get to section 10, which the two versions were fairly different. So the Senate proposal here would go back to something more like what the Senate had proposed, but using the those consensus recommendations from AHS, Green Mountain Care Board, and Healthcare Advocate. Although some of it was me trying to figure out how to make it work. So if I have missed anything, hopefully it will be corrected. So this would go back to codifying it. It would direct the agency to collaborate with the Health Information Exchange Steering Committee in the development of, and then instead of an integrated system of clinical and claims data, it's the Unified Health Data Space. That's the name that they had given in order to improve patient, provider, and payer access to relevant information and to reduce, instead of administrative burdens, it would be healthcare system costs. The agencies, instead of process development of the Unified Health Data Space shall align with the HIT plan. So everything in yellow was already in the Senate version. Utilize the expertise of the Health Information Exchange, HIE Steering Committee. Incorporate appropriate privacy and security standards that are aligned with the best privacy and security interests of patients. All right, here's where I had to do some massaging, so hopefully we didn't miss anything. Determine how best to integrate clinical data, claims data, data regarding social drivers of health and health-related social needs, and other data types. Provided, however, that integration of these data types or a subset of them shall occur only upon the favorable vote of a majority of all voting members of the HIE Steering Committee, and only for the specific uses approved by the Steering Committee at the time it approves the data integration. I don't know if you want to be that time limited, but that is what was suggested in their language. And then if data is integrated in accordance with subdivision 4, limit the use of the integrated data to the specific uses approved by the HIE Steering Committee. Ensure interoperability among contributing data sources and applications to enable you. So the language from the Senate was to enable a unified health data space that is usable by all stakeholders. The proposal was, I believe, to just say to enable use of the unified health data space. I don't know if you want to say anything more than that. Identify the resources necessary to complete data linkages for policy, health surveillance, population health management, and research usage, and for the data integration uses approved by the HIE Steering Committee pursuant to subdivisions 4 and 5. Establish a timeline for setup and access to the integrated system. Develop and implement a system that ensures rapid access for patient, payers, providers, and payers, and identify additional opportunities for future development, including incorporating new data types and larger populations. It would strike the requirement for health insurers to provide data. Would require the agency to provide access to data to state agencies and healthcare providers as needed to support the goals of the statewide healthcare delivery. I added back strategic plan once established to the extent permitted by the data use agreements in place for each data set and the uses approved pursuant to subdivision B4. And then there would be an annual update on the development and implementation of the unified health data space in accordance with this section. Again, this is largely the consensus group language, so if you have specific questions about it, it may be for them as opposed to.
We're
The
fine
senators.
with the consensus language. Takes a step forward, particularly with regard to what we have heard in the past, and then what was consolidated in the Oliver Wyman report for access to clinical data, both by patients and providers.
Topper,
On page 33, line 16. We're taking out usable by, I think it is.
Yeah, I know, it's very hard to see in the printed one.
Well,
Yes, yep.
What we want to get to is all stakeholders using
Right.
that system.
So in the first part of that sentence, it talks about the interoperability among contributing data sources.
That's the part that I'm worried about.
What are you worried about?
Among those contributing. It seems like, I like to use the term, they shall contribute.
Oh, I would love that too.
If we don't, we're gonna end up, this is my own opinion.
Yeah,
We're gonna end up right where we are, certain people not doing it and certain people doing it. And we're trying to move those people to use it. It works well, I know, because when I was down at Dartmouth, my stuff was there.
exactly.
And it really helped the doctors out.
And
Because something had to be done, well, me, big
Yeah.
time.
yeah,
It had to be done right away. They needed to know stuff about me to do it. Anyway.
so we did take the paragraph out about having payers,
Right, insurers. specifically
Insurers.
Insurers.
Yeah.
which would be, icing on the cake.
can I ask a question about that?
Yeah,
Because we do have in here that it is accessible and contributing payers. Is there anyone else who has,
I don't know where.
it says ensure interoperability, well, you have
among contributing data sources, that
among contributing data sources, and then, let's see. I'm sorry. I'm trying
Oh, the
to-
rapid access on number 9
Rapid access.
for patients, providers, and payers.
Yeah, am I the only one who has a concern about payers having access to clinical data?
No.
Sorry, I'm looking at a paper. We did a bill last year specifically to make it so that payers could not ask for medical review, pre-payment medical review. I find it very alarming that we would be encouraging an integrated system that payers would have access to clinical data.
that they haven't contributed. So, well, that they don't, for their specific.
For their purposes.
Risk pool. Okay, so yeah, that's a good question. This is a question, I think, this is the language that came from the Healthcare Advocate, AHS, Premium and Care Board, but I do have that. Now that you bring it up, it's an
Right,
important
well, this was,
concern.
what's in yellow was in the
What is
Senate
this?
version.
Yeah. Ah,
So-
our version,
Yes.
we did it.
So I don't, so it, and it was maintained in the consensus language. got, but I don't know if the people who,
So we need to phone a friend on this and decide, is this something that would place patients in jeopardy? You raise a really good point.
The other concern that I have in, we had this section as essentially a report out. Because what we heard from our witnesses and what we heard from providers was, we don't need all this other stuff. We just need the ability to, within our own health record,
The interface.
the interface.
Mhm.
And by removing the, in little a, section 10A, you removed information to reduce healthcare system costs. I would add that, I would ask that we add administrative burdens back on. Because what I imagine is that we're going to develop, and
Okay,
AHS is going to develop a unified health space, which is built upon the premise of what Vital is, which is an outside sign-on, which has great intentions and no one uses it.
so you want to take out administrative burden on providers?
I'd like to add,
I mean, that's what I mean.
I'd like to.
Sorry,
add
take
that.
out the strikeout. Yeah.
To me,
I'm fine with that.
this is what, to me, this is what section 10 is about. And not about.
I think this was the
reporting or
consensus.
Quality.
This was the
group,
consensus
So this was
group.
not a
I'm
specific
saying
decision.
that I would agree with that. Well, if the consensus group comes back with legitimate concern, fine, we can listen, but I agree with you.
Okay.
I think we agree.
All right, so we'll work on some language around our concerns with payers.
Uh-huh.
And
Sure.
I'm sorry, Daisy, you had a question.
Oh, just kind of big picture. It looks like with this consensus language or the green, just big picture, is this language? So up top, the unified health data space, I interpret that as sort of a data warehouse that facilitates research, whatever, yada, yada, yeah. Okay,
I think I would, it's a particular something that is being created by, at AHS, and I know they have sort of the data warehouse, the data
The
lake, the data
DWAS.
something else, yes, so I don't know which category
Yeah.
this one falls into.
I've got that, I think. And then separately, under, I understand it that there's a requirement basically that kind of requires a universal health record, meaning that we have to, like, people who contribute have to contribute in a manner that. Okay. Ensure interoperability among contributing data sources and applications to enable a use of the unified health data space. Is that intent? Does it require them to use the same electronic health record?
I think the
Interoperability.
interoperability doesn't require anything, but it means that you would have an interface with the clinical data. We're trying to get to a place where every provider can access clinical data about any patient that walks in the door who has data out there.
Right.
So it's,
But I think it's a compatibility issue, not
yeah, it
necessarily
is
the
a
same,
compatibility
not
issue.
necessarily the same software.
Yeah, so.
So I'm
and-
thinking about financial
Yeah.
capabilities of all our providers.
They might not be able to do it, and that's
Right.
one of the problems.
We do have in here, didn't I see a piece that says what are the barriers?
Identify
Yeah,
the resources
identify the resources,
necessary.
yeah.
Yes, that's it. So, yeah, there's a lot embedded in here that means investment. And we, obviously, when we start talking about the HIT fund, there's
Yeah.
a discussion to be had there.
Yes.
And so much of that work's going to be explored through further down. We have. Yeah, okay. The
Okay.
rework on this is really great.
So,
Yeah.
so we'll take a look at this section. Maybe work with Jen and come up with a counter proposal on it.
Uh-oh.
All right. Then we're into section 11, which was around the Green Mountain Care Board sharing materials that it receives pursuant to subpoena or notice to produce, with specifically AHS or DFR, not any state agency, and Senate has proposed keeping that change. Sections 11A through 11D, there are few changes to, although I understand some of this reporting and other reporting may still be a work in progress. But they did suggest in 11B, which is the Act 167 reporting, based on some of the suggestions, I think, that came through AHS, this would take out the specific July 1st date and instead have the agency report on this list of items on or before the first day of each month, beginning August 1st, 2025, with an end date. This did not have an end date, but could probably use an end date through January 1st, 2027.
So that was a recommendation from the agency, you know, the startup date seems fine and appropriate, and then an end date. And we, honestly, I think that we as a group need to talk further about that whole update section.
Okay. And they should have completed their 167 work by January of 2027.
I think you can decide where they are at that point. And whether you want additional reporting or something else.
Yeah.
11, I will say, note that 11A has monthly reporting without an end date, so you may want to just look at adding an end date
Okay.
on that, or you could decide when you come back next session, you're ready to be done with those.
Okay. Can you flag that for us when we have our section from discussion?
Yes, 11A. Oh, you mean as part of?
Yes.
Yes, we'll discuss this whole.
Yeah, we'll discuss it.
All right. Great. Then we have no changes on 11C or D at this point, no changes on section 12. For the Green Mountain Care Board February 2026 report, they've added back in development of global hospital budgets as part of the reporting. And taken out the House language about reporting on potential future use. No changes in at least at this point, in the annual AHS report, although again, some of these reports you may be revisiting. Section 16 is the Green Mountain Care Board annual report, and replacing, again, any considerations regarding the future use of global hospital budgets with the original Senate version of development of global hospital budgets. No changes in the positions, and in the appropriations, there's language at the end just saying it is the intent of the General Assembly to provide sufficient resources in future fiscal years to enable the board to fully implement global hospital budgets in accordance with that provision in the hospital budget review section. And then finally, the updates to the effective dates that I mentioned yesterday. So just be section 16 that would be effective July 1st, 2026. Section 17 and 18 would be effective on July 1st, 2025, and everything else would take effect on passage.
All right, so it seems like pretty much from 11B on is just simply incorporating the global budget pieces back in.
Yeah.
Mainly, yes, with the caveat that some of the, I think, reporting.
Some of the report,
still.
we'll be looking at all the
Okay.
reporting section, so one more time. Yeah.
And you haven't had a chance to look at that either on AHS's recommendations. Neither have
I scrolled through it.
Okay.
We saw the dates and some of the other things, so we'll look at that again.
Okay.
Yeah, be good for both of us to do that. Okay.
All right.
So we heard you on the advisory committee. So you'll be bringing us something there on those two additional
Okay.
there.
So can you, when we received the bill from the Senate, obviously it had global hospital budgets in it. We had understood that the positions required to do that had sort of been downsized a little bit, which is why I think we removed it because we really wanted to get to, reference-based pricing, seeing how we could, reallocate resources within our system of care, ensuring that the statewide healthcare delivery plan, did the strategic get removed?
No.
Did you, oh, you kept strategic, okay. The statewide strategic.
That was a
healthcare
big
delivery. We wanted to ensure that that was completed, was fully completed, and that reference-based pricing is fully in effect and allow hospitals to acclimate to the changes that we think will be coming. So so that is why we removed global budgets. It's not as though aspirational, we don't agree with the concept at all. That would be great. I do notice that in your language, there actually isn't anything directing anyone to define what a global hospital budget is. And I really do think we need to do that because, as I said, every person you talk to has a different idea of what that actually is. So we should put our intent in there of what we either think it is, or we should task the Green Mountain Care Board with coming up with what it actually is.
So that would be a question for the board. And potentially for AHS, we'll be working through if and when AHEAD has global budgeting in it, there will be a discussion going on there. So, I think the board has the capacity and the capability to do that. There are different models out there, and I've met with folks from different states to talk about it. The Millbank Fund obviously has expertise in that area. And it will be different. It depends on what's good for Vermont. So I'm not sure at this point we can say what it is that is global budgeting for Vermont, but I think the board is probably the right place to go if you want some kind of operational definition.
I was hoping that you could
Ken?
Sort of give your argument of why you think it's vitally important that it's in this bill. And the timeframes of it that you have on it.
So a lot of hospitals currently use reference-based pricing. We know that, right? It's out there being used. And in some ways, it's being used in a way that allows for specific, highly utilized services to get a high reference-based price. So the work that the board will do will make definitions about the use of reference-based pricing dependent on the services, the utilization, and so on. So that will happen, and it's within the context of what hospitals know about, right? Global budgeting will establish that cap for, it's not just a single budget every year, but it will establish some guidelines and goals within which budgets are developed. So it could be a way of an algorithm that analyzes every year how much money should be put into the kitty for budgeting. It could be done differently. It could be done hospital by hospital, which probably isn't the best way. You can do it by hospital types. But I'm not the expert on this. All I know is that if you don't have some kind of cap, you're going to see an escalation. You're going to see an increase over time. And we're just going to see the same thing happen that we've seen before, regardless of what we do with reference-based pricing.
Do you think that the process that the Green Mountain Care Board does right now in establishing net patient revenue, do you see that as as a cap and a global
Well,
budget?
you know, there's also the debate about whether we look at net patient revenue or whether you look at hospital expenses. Do you look at total cost of care? And that's what we have here in the bill for the board decision making. So I've heard from one expert that we should be talking about hospital expenses. I'm going to be looking at that one again, you know, so bad time to try and throw that out on the table. So there are different ways of budgeting. And again, I'm not an expert in the budgeting process at all. The board has that expertise. And so do hospitals. Hospitals understand. So you're asking for something about global budgeting definition. I'll see what I can do in terms of, you know, reaching out to the board or others and try and get something in here that would help.
Just something that would help us.
Yeah.
You know, in
And
developing
yeah.
global budgeting, part of their development process should be what is a global budget.
Exactly. And what, you know, look at what we haven't talked about is how practitioners are paid or services are reimbursed. You got block grants, right? You've got all payer models. You've got all the fee for service down here and going up. You know all that, right? So that reference-based pricing can be used in different ways. And that's a discussion that happens at the board. Where we can direct that conversation the same way we can direct a global budgeting conversation. We're just at the beginning.
That's, I was just gonna say, we're at the beginning of global budget. Hospitals are now asking for it. They must have an idea of what it means to them.
I don't know if hospitals are asking for it, you know, but I think it's a good idea to have some kind of a,
I've had some hospitals
yes,
say to me.
Yes.
"We need global
yes.
I've got some hospitals who a year ago said, no way, who are now saying we should have global budgets.
Yeah, so it depends.
Yes.
Yeah, so and things evolve. So I think we're putting in place something that will allow that evolution. Yeah, really. And it's all like sausage making, isn't it? And
The cap is key.
Yeah.
Yeah.
I will say that I was thinking about this, you know, global budgets, not global budgets in as it pertains to this bill. And I would just say that I read an article in one of our daily news. I was gonna say paper, but it's not a paper.
Outlets.
About one of our hospitals who is talking about cutting costs, but also needing to generate new revenue and things that they were planning on purchasing strictly because they needed to generate revenue. And I thought to myself, this is why we need global hospital budgets.
lots of different,
Because that is the exact reason why we have gotten into the, I will say, the mess that we are in.
overutilization, high cost for
The wrong
services, right?
wrong services.
Right. Exactly.
Driving care to the most expensive
Huh,
services.
sounds like prescription drug.
Yes, exactly. It does sound like prescription drugs.
You know,
And so, I mean, I'll talk with the rest of our committee and we'll see if we can get this in here.
Okay.
Easy.
Oh, I was just gonna say, and a lot of focus historically on payment reform and not a lot on service delivery reform.
Mhm.
So I'm excited about this.
It is. It is exciting.
Yeah.
It is very exciting.
Okay, so I think, is there anything philosophically that we wanted to talk about? Thank you so much for preserving the primary care comprehensive Vermont statewide.
The Vermont.
The Vermont strategic, for whatever we want to call it. Because that's, I mean, I said this yesterday, 50% of the care in the state is delivered by within primary care, and they currently consume less than 5% of the money that we spend on healthcare.
So, and so we share that concern. Obviously, when I sat over here and presented the bill and I asked you to please improve the primary care presence in the bill, and you've done that. We do also need to be very sensitive to what the blueprint is and what they do. We need to be sensitive to the advisory committee that the board has, and we need to be sensitive to the VMS work that goes on with primary care. I mean, honestly, I'm hoping that this group can consolidate and bring together all of that to make recommendations. And then the other thing I want to say as we go forward, I mean, we need to consider that we need hospitals. And
Absolutely.
we would be lost without them. So we need to take care with how we regulate. Not we, the board.
And just anecdotally, when I was working with Jen on language, we had discussed whether or not we should just sort of change some of the other committees that are currently in existence. And it was decided that we would create this new one, and the intent is, as it's also the intent with the HRAP, that this statewide strategic delivery, that we can sunset out HRAP, and this will take its place. And it's my intent that we can maybe sunset out these other ones if we have a very, very strong, comprehensive primary care presence. And to the evidence of how important I think it is, and how I feel as though, because they have previously been in just advisory roles, I reached out to the board I think it was 4:00 on a Thursday. And I said, can someone from PCAG come tomorrow? And at 9 a.m. on Friday morning, we had 3 providers, and they were excited because nobody ever asked to speak with
Oh, I
PCAG.
asked them about that.
They
But you
were
forget.
us, and they, they gave us some great information. So, yeah, we should.
They are
consider
good.
them. Yeah.
No question. Okay, so
Okay.
please
So
consider
let's-
the recommendations that we've made to you. We feel very strongly about what we have presented to you. And we will go through the last sections on reporting pieces so that, I mean, my concern on all the reporting, as we said before, they need to be updates. I would rather have AHS and other organizations, hospitals included, out there doing the work, boots on the ground, than coming back and telling us what they're doing every 5 minutes. And I know that's not your intent, but we want to make sure that that's very clear.
It's not our intent to make
No.
more work for them.
Yeah.
It's just update on what work have you been.
Right. Got it.
So let's meet back. You all have an 11 o'clock.
Uh-huh.
Um,
Probably be an hour at the very end.
and do we have floor at 1? We do. Can we meet back at 1?
I think so.
Will that give everyone enough time?
And it depends on the floor time. We have right now, yes, because we could meet with Jen, maybe.
I'm gonna need to meet with this House conference next.
Okay, and we could meet at 12, maybe?
Well, they're gonna be on the floor as well. Yes, maybe, when you're on the floor.
We go to the
we
floor
both
at
Go to the
2.
floor at 10.
Okay, but
It
there's
doesn't
not-
look very long.
There's not an afternoon. Okay.
Our floor time might be short. Really
I think
short.
our floor time is short.
Yeah.
When are you meeting with?
Probably right after this.
Okay,
No, we have floor.
We have a short
Noon?
floor.
We meet with you at noon.
all right, when we're off the floor, I'll let you know.
Okay. All right, so let's start with 1 right now. If we need a little bit more time, then we'll move it to like 1:30. Is that okay?
Yeah, and if we can meet earlier, can we?
We'll sort that
communicate with
out.
That too?
Yeah. but we need to
Okay.
meet with Jen.
We'll keep in contact, but we will aim for afternoon,
Yeah.
early afternoon.
We may be